Good evening, everyone. Thank you so much for joining us for tonight's presentation on canine joint injections. Why should horses have all the fun? Tonight's presentation is presented by Dr. Jennifer Repac. Dr. Repac received her DBM from UC Davis in 2009, following which she spent her first 4 years in general practice and shelter medicine in New York City. She then spent 2 years working as veterinary for an small animal practice in Beijing. Her love for teaching abroad led to her to complete an integrative and rehabilitative medicine specialty internship, followed by a residency at the Animal Medical Center of New York. Dr. Repag is now a clinical assistant professor at the University of Florida. Also joining us tonight is Dr. Meg Green, Technical Services Veterinarian here at Kentura Vet, who will help moderate and lead tonight's discussion. At the bottom of your screen, you will see a Q&A dialog box. Please feel free to submit your questions as they come top of mind, and then we will answer them at the end of tonight's presentation. So without further ado, Dr. Repug, the floor is yours.
Hi, thank you for everybody for joining me after probably a long day of work. This is a topic that is super exciting and a great passion of mine in what I do. And I hope that you guys will learn to love it too once you get your feet wet. So a little bit about me. I think actually I already got introduced about my little meandering path, so I won't go into that again, but I am at the University of Florida and very, very lucky to have a department with a robust residency program and specialty internship program, because spreading the good word of rehab and mobility medicine is what I'm truly passionate about. And because our college, our specialty college, is the newest college, and a lot of the public and veterinarians haven't heard about us before, I always take a moment to explain what is the American College of Veterinary Sports Medicine Rehabilitation that I'm a part of. And I think some of the confusion lies in when we hear the words sports medicine rehabilitation, you usually think of dogs that look like this, or perhaps ones that look like this. And I think you can all guess how many sled dogs I actually see in Florida. None. And also greyhound racing is illegal in all but one state, West Virginia, currently. So actually I see very few greyhounds. And occasionally I might see an agility dog from time to time, but we would all starve to death if our salaries depended on these patients. And the majority of my patients are actually patients that look more like this little guy. So the way I explain it to people that haven't heard of sports medicine rehab before, I say that it's more like mobility medicine. We do everything except surgery to help animals move better. And so geriatrics are a big part of our patient population, but we also treat working dogs and more dogs just like this. So the French Bulldog is universally keeping all veterinarians employed and giving us a lot of work to do. So starting off with my conflicts of interest, I am a consultant for Kentura Vet and also for Wolf, such a supplement company, but I have no other conflicts of interest to declare. So my first question was just for the group, just opening up there, and I don't know if this is like super easy for people to kind of chime in, but I just want to know if anyone out there is already using any joint injections in dogs. Are you able to put in the chat? Actually, I think Rachel is able to see the chat.
Yes, I can. So you guys can go ahead and put it in there, and Jen, you should be able to see them too, the responses.
Okay. And if not, that's totally okay. I'm getting a little bit of crickets, so maybe nobody, I'm guessing, which is great because that means that there's a lot to talk about. I'll just go ahead and move on. So the objectives of this lecture are to talk about first, why is OA important? Why do we need to treat it? When do we need to use joint injections? And going into sedation and prep, basic technique, diagnostic applications, including cytology and blocks, and then diving into our injectable options. Lastly, we'll talk about some practical points. I think somebody raised a hand. Oh, I guess you're just saying that you do joint injections, probably is what that means. Thanks, Carrie. So why is it important to talk about OA? It's because we create dogs that look like this. This is not a morphologically the most normal of canine structures. And so from this, we develop a lot of dysplasias in our canine patients. So 20 to 40% is the statistic of how many dogs in general have osteoarthritis. But it's important to remember it's not just a old age disease, and that many of these congenital joint incongruities, like your hip dysplasias, your elbow dysplasias, will result in osteoarthritis. While osteoarthritis is incurable, it's also very manageable. And unfortunately, it's still considered the cause of euthanasia in dogs, with about 41% of owners reporting to consider euthanasia in dogs that have arthritis, which is deeply concerning. And so just reviewing the pathophysiology of osteoarthritis, I think a lot of us tend to focus first and foremost on the cartilage. Oh no, the cartilage. And yes, the cartilage does become fibrillated and destroyed, and we can have these gaping holes in the cartilage by the time that we're seeing things on our radiographs. But there's also an entire organ system that is also failing. So we have the thinning of and decreased viscosity of the synovial fluid. We also have inflamed synovium. The synovial lining gets angry and the joint capsule gets thickened. And so there's multiple levels in which that osteoarthritis can act on the joint. And unfortunately, just as a first and foremost point, there are no therapeutics that can regrow cartilage. There's a saying that once a chondrocyte goes to heaven, it never comes back. And it's unfortunately true. But we do what we can to manage this disease. So big question is when to use joint injections. And I can say that you're going to get different answers to this depending on who you ask. And the culture is shifting in the canine world right now. The first and foremost thing is to establish a diagnosis. And I bring this up because I think probably some of you out there have heard of Librela. And I know that this talk is about joint injections, but Librela has really brought to light how, first of all, a lot of people are seeing osteoarthritis in their patients and they want to treat it. But some of the side effects of Librela have highlighted that perhaps we are not diagnosing our patients as specifically as we can be, and specifically meaning that we are seeing a lot of patients with pre-existing neurological disorders that perhaps are misdiagnosed and then worsening as a result of being given Librela. I don't know if any of you all have seen things like that, but it's something that we see on a fairly frequent basis. So remembering that we need to take some steps backward and to identify osteoarthritis completely. And so this is a typical example of a patient that might present to my clinic for hip dysplasia and hip arthritis. And so if you watch this patient walk, you can see we've got crossing over the hind limb, some obvious ataxia. We even got scuffing of the nails. And so this is a very common situation where someone will see an older dog. Here he's not moving so well, must be arthritis. And a dog like that might get Librela if radiographs were not taken to show that there's no arthritis. So I always emphasize that every patient that comes in for mobility exams should have a neuro exam just to make sure that there are no neurological deficits, and then radiographic confirmation of arthritis. And also, it's important to remember that our treatment of OA is multimodal. So joint injections are a nice piece of this puzzle, but there's also supplements. Weight loss is a big one, exercise therapy, pain medications, and then also the modalities that we offer you in a hospital and the rehab clinic. So in terms of the role of joint injections in OA management, I look to firstly our equine friends who are a little bit ahead of us. They're more like in the future in the sense, because sports medicine and rehabilitation has been bigger on the equine side for a number of years. And equine practitioners have been doing joint injections for much, much longer. And partly it's because there's maybe a lot more money that's invested in the mobility of horses. Maybe they have also just bigger joints and it's an easier target. Um, but it is very commonly used. And most of the time in equine medicine, HA and corticosteroids have been used. There's also a lot of blood products that are used, like platelet-rich plasma, and very low rates of sepsis, about 2 in 10,000 have been reported. So generally pretty safe. Now going on to our human medicine friends, also a little bit in the future as well. According to the 2019 American College of Osteoarthritis guidelines, actually joint injections are considered one of the strongly recommended group of therapeutics for both knee and hip osteoarthritis. And that's among other forms of multimodal management, including weight loss, Tai Chi, exercise, etc. So patient selection, I think this is an important point. There's a bit of a debate. When do we intervene? Do we go early in the disease? Do we save it for last, or do we do it pre or post operatively? And I think it depends on what your injectate is. But in general, I think you can say this with a lot of diseases. If we wait until our patients are end stage, our abilities to make them better or make a huge improvement in their quality of life are going to be less. If we can maybe intervene before our patients look like this, we're going to have even better effects in our patients. And so recently there was a group called the COAST, the Canine OA Staging Tool group, and they created some guidelines for the treatment of canine OA. And this is a lot of information on one page. It kind of violates my rules, but I just wanted you to focus on, they considered for dogs with moderate OA, and they mean by moderate in terms of being clinically affected, joint injections were part of their core recommendations among the other multimodal management techniques. And so there is maybe a little bit of subjectivity in there, like what's moderate versus mild, mildly clinically affected. But they are saying that, this is not something that you should wait till the radiographs necessarily look really bad. This is more based on clinical signs, which I think is very reasonable. And I think also something to consider too about not waiting till the rads look that bad is that by the time we are noticing changes on radiography, which is this point here on this timeline, that we are already in the painful and irreversible stages of osteoarthritis. And so, and CT is actually still in that line too. Diagnostics that would occur earlier are just things that we just don't do in dogs, like compositional MRI, looking at the cartilage composition changes and things like that. But I think the point of this diagram is just to show that even though the radiographic signs will look subtle, that we're already in a pretty irreversible stage of the disease, and to take it seriously. So moving on to sedation and prep. Our sedation protocols, pretty basic, dextrometer, butorphanol in combination. Depends on how nervous the dog is. We're doing anywhere from 5 to 10 micrograms per kilogram IV, butorphanol 0.2 mg per kg IV. If you have a nervous dog, you could do this IM instead. And in some of our patients that are quite nervous and maybe we need to pull a blood sample for them for PRP and we don't want to collapse the veins, we might do lower on the dex and give a little bit of ketamine. So a little bit of DKT combination instead. That's like our little bit of flavor for those Belgian Malinois getting PRP. And then post-procedure pain management, this is highly dependent on the individual. Most of our pain or our patients are able to go home on the same medications that they were already, and that's fine. But if you have a patient that's more sensitive, considerations would be NSAIDs, acetaminophen. I only use codeine or tramadol if I'm already using these other medications, like NSAIDs or gabapentin, because tramadol and codeine just don't have as high of evidence for bioavailability in dogs. Lidocaine patches also can be kind of nice after injection in some of the sensitive small breed dogs that I used to see at AMC. And occasionally some dogs have given a methadone injection afterwards if they seem particularly ouchy. But I would say most of the time, none of this is necessary. So going on to technique, the materials that you need are pretty basic, things that you have around the hospital, your 22 gauge hypodermic needles, 3 to 6 ml syringes, clippers, scrub, sterile gloves, whatever you're injecting. And then if you're planning to do a joint tap for diagnostics, you just want to make sure you have all your stuff ready. So like your slides, your purple top, and your culture media in case your sample has some blood contamination and clots. You don't want to be just sitting there and not be ready. So going into your preparation, of course, you want to clip the fur, aseptic prep, which is pretty similar just to like surgery. And actually, I should have said this before, but you want to identify your landmarks and sometimes bring the joint through range of motion ahead of time to palpate where you're going to inject and then maybe scrub afterwards. But having that identified ahead of time can be nice. And then put on your gloves and slowly introduce your needle and redirect as needed. And then aspirate and then replace with your injectate. If you get some blood contamination, it's not the end of the world. We usually just like pull out and then, do a new restart with a new syringe and needle. So which joints? We actually have these graded in a scale that's similar to the ski slope scale. So we have like our beginner joints, like the carpus, elbows are kind of more like intermediate. Shoulder, I think that's considered pretty intermediate. Tarsus is more of like your black diamond. Stifle is a good beginner. And then you have your hip, which is like the double black diamond. So starting with the carpus, beginner joint, your position is you want to flex the joint and identify the radiocarpal joint, which is the most proximal joint here. And you want to go right in that joint. Here's also another shot of going into the middle carpal joint as well. And you just want to make sure that you visualize any tendons. You can just avoid piercing those. When you inject the carpus, it's going to be a very small volume, like a 0.5 ml to 1 ml. So a little brief video of what that looks like. And that's it. And then after that point, you would just fasten your syringe and then aspirate, remove any joint fluid, and then attach your new syringe. So going on to the elbow, your position is going to be in partial flexion and abduction with a little towel rolled under the joint as a fulcrum to open the joint space. And so when you go medially, you're going to be just caudal-distal to the medial epicondyle of the humerus. And of course, you want to make sure you avoid the ulnar nerve, which is going to be caudal. And your volume is going to be 1 to 2 milliliters that you're approximately going to fit into that joint. So a video of what that looks like. And so the needle should just, when you actually hit the elbow or most of the joints, they kind of sink in a little bit as you hit the right spot. So going on to the shoulder, which is your intermediate level. For the shoulder, your limb is in a neutral position with a little bit of distal traction to open up the space, which might be in the form of slight adduction off the table. And your approach is going to be subacromial. So starting caudodistal to the acromion, avoiding the biceps tendon. And usually it's a little bit of a bigger joint. You can inject maybe 1 to 2 mLs in that space. And that's what that looks like. So going on to the tarsus, which is more of your expert black diamond level, the position is going to be slight tarsal flexion, as shown. And there are several approaches, but the lateral approach is between the lateral malleolus and the distal tibia, parallel to the calcaneus. So it's going to be at this like quite a sharp angle, hugging pretty close to the calcaneus. And you want to make sure you avoid any vasculature in that area. You might feel fit like 1 ml in there, but it's not a very big joint. So yes, we actually just did one today with ultrasound guidance that was quite difficult, and they did not get any joint fluid from that joint. So if you have a very diseased joint, sometimes you won't get that fluid confirmation. So moving on to the stifle, which is everybody's favorite beginner joint. With the stifle, you want to be in stifle flexion with a little bit of external rotation. And you can approach either medially or laterally to the patellar tendon, midway between the patella and the tibial tuberosity. And it's going to be just adjacent to the patellar tendon, aimed towards the popliteal lymph node. You want to avoid being in the infrapatellar fat pad, definitely not through the patellar tendon. And the way you tell that you're not in the infrapatellar fat pad is you should be able to get a flash bat in this joint if you are not in the fat pad. And the joint injection volume could be 1 to 2 mLs, depending on the size of the dog. Like so. And then the hip, which is the most deceivingly simple injection, where it's just, it seems like a really big joint and it would be quite easy, but it does give people a hard time in that it can be pretty tight. Often when we are injecting, there is a lot of osteoproliferation in the area. So it can be a very tight, curvy space. The position is slight abduction with gentle retraction. And the approach is just proximal to the greater trochanter and aiming slightly ventrally to go along with that curve. And you may need a longer needle especially in the giant large breed dogs. In some cases, a spinal needle might be useful, but most of them can be done with a 2 to 2.5 inch needle. You want to avoid the sciatic nerve, of course, which lies caudally to the greater trochanter in the sciatic notch, and usually can inject about 1 to 2 mLs. Okay. And actually, more recently, we have been doing that more and more with ultrasound guidance as well. That's a very helpful tool for going into the hip. So some notes about arthrocentesis. That can be a very useful tool. We do see a ton of IMPA in Florida, and I don't know what is with that. But arthrocentesis, first of all, it helps confirm that you're in the joint space. If you get that synovial fluid that's nice and viscous between your fingers, then you know you're in the right place. It's also just quite easy to put that on a slide and take a look, and just to see, like, you just don't want to see a lot of neutrophils. That's the point. Like, you want it to be pretty clean, pretty acellular. The occasional monocyte is normal, but if you see a sample that looks like this, you're either worried about either sepsis, a septic joint, or autoimmune disease. And then fun little thing about diagnostic joint injections, those can be helpful in your cases where you're not really sure if that particular joint is the cause of lameness. And so this is borrowed from our equine friends, but it has been studied in dogs too, where you give the dogs a little bit of sedation, then you inject a little mepivacaine into the joint, and then reverse them. And they showed that you can actually, effectively reduce the lameness this way. But this is not going to be an approach for your subtle lamenesses cases. You want to make sure that these are good, hardy, at least 3 out of 5 lamenesses that you're trying this out on. So then the big question is what to inject. We have many, many choices. Essentially, I break it into a couple of categories. You have your orthobiologics, and then you have your non-biologics. So orthobiologics is broken down to your blood products and your stem cells. And then within those categories, you have your platelet-rich plasma, autologous conditioned plasma, which is it's basically kind of a platelet product or a blood product that's branded from Arthrix, which is what we use. And then you have stem cells, which are either derived from bone marrow most commonly or adipose derived. And when we're talking about regenerative medicine, you have a couple of major categories, either autologous products, which are from the patient's own body. And those usually require some sort of processing, whether they're on site or separate. And if you have a very unhealthy patient, that might affect the quality of the products that they produce. Versus your allogeneic products, which are coming from a different patient, and those are off the shelf. And there's not that many of these products available right now, but they're coming to be more common. Of course, if it comes from a different patient, it's going to have more potential for immune reaction. And one of the big questions is also, is this as viable as these fresh samples that we're obtaining from the patient? So starting with platelet products, how do they work? Essentially, they help modulate inflammation. They release growth factors, including platelet-derived growth factor, transforming growth factor, and vascular endothelial factor. They have antibacterial and fungicidal properties, and they also have calcium ions, histamine, serotonin, and dopamine. And so the pros of platelet products are that they're very easy to process on site. And the cons are that it just often requires a large volume of blood, and that can be kind of annoying. And I can say I've had a few patients recently that have really, really lipemic blood, and there's just nothing you can do about that. You can't inject that in the joint. And so that's been pretty inconvenient. And we had to choose something else. And the other thing about platelet products is that the effects are usually short-lived, and then so they require being repeated, usually monthly. And then typically that's good for the year, but that's not always feasible for everyone. And so preparation-wise, the blood volume varies by system that you choose, but it could be anywhere from 15 mLs to 30 mLs from the patient. And the quantities or percentages of the platelets, white blood cells, and red blood cells vary per system. So I think displayed here we have companion, and then this is the ACP from Arthrex. I think this is the Angel system here. And then the new kid on the block is Precise PRP, which is the off-the-shelf allogeneic product. I actually don't know very much about it, but I thought maybe some of you might have heard of it, so I decided to throw it in there. So for platelet products, what's the ideal amount of platelets versus red blood cells and white blood cells? Like the exact number, I mean, people have an idea, but it's really not something that is set in stone. There's a lot that's more that we need to research. But in general, the idea is more platelets, less neutrophils, less red blood cells, and maybe monocytes could be helpful. Even like lymphocytes sometimes could be considered helpful, but that's all kind of a little bit in flux right now. And just to give you an idea about the range of variability between these systems, this is the range of how much platelets are in the post-process sample. So this is whole blood is the dark blue, and then the light green is like what the system outputs. And you can see it's like in this case, they go up this much. In this case, they go down. They go up a lot in this case. They're about the same here, and then slightly more here. So it's really highly variable. And then going on to mesenchymal stem cells. They work by secreting anti-inflammatory cytokines, extracellular matrix molecules, and growth factors. So there is some overlap with platelet-rich plasma, and sometimes they can be used together to have a synergistic effect. They can also recruit circulating stem cells. And I will just say one thing that they do not do that is a misconception is that when you inject stem cells into a joint, you are not regrowing cartilage. We wish that we could. If we did, we could do that. We would do stem cells on every single patient. But unfortunately, the stem cells, they go into the joint and it's very cytotoxic in there from the inflammation in the joint, and then they just like die right away. And then they just secrete their trophic factors basically. And then they leave. So there's really not a lot of like, there's not actual growth like we see in like maybe the movies with stem cells. So pros of stem cells are that it has a nice length of effect, so about 1 year. Cons are that they're quite expensive. So you have to harvest them from the patient. So there's a procedure charge there. Then you send them to an extra storage facility where they bank them. And so that's thousands of dollars. And not everybody is game to do that fat or bone marrow harvest. And the offsite processing is a bit of a kind of a pain. And many products also have not been tested for efficacy, so that's important to note. So then going on to biologics, or non-biologics rather. So this can be broken up into several different categories. You have your corticosteroids, hyaluronic acid, hydrogels, and the radioactive isotopes. All those last couple categories are a little bit on the newer side. So corticosteroids, nice and cheap. So I think we know how steroids work. They're really great at just decreasing inflammation through the LOX and COX pathway. They suppress all sorts of inflammatory cells, your lymphocytes, macrophages, and mast cells, as well as your catabolic enzymes. Dose can be 1 to 3 milligrams per joint. We're usually using triamcinolone. And the potency is similar to prednisone. And sometimes you can have a range of 0.5 to 0.7 mg per kg total being used. So what's nice about corticosteroids is they're super cheap, really available, and you have this instant gratification where they work pretty quickly. However, there's always a downside, and with steroids, we all know that, you know, they can make everything great and then not so great after a while. So the short term, there's a very short term efficacy period, so 1 to 2 months. And they also can have chondrotoxic effects through inhibition of proteoglycan and collagen synthesis. So, I mean, if you had an end stage joint like those horrible hips on that radiograph that I showed you before, like, is there any cartilage left to preserve? Maybe not so much anyway. It doesn't really matter that much. But we don't tend to use them chronically in many patients for this reason. You also might have to worry about ligamentous weakening too with chronic usage, as well as potentiating septic arthritis and sterile synovitis. One advantage, and actually this isn't our con, but it's not just a little bit of a note really, is that at the doses that we're using, they're unlikely to have systemic effects. And the adrenal cortical suppression has been shown to resolve in 7 days, according to one study. So going on to HA. HA is basically like the lubrication in the joint. It's a viscosupplementation. And so it helps lubricate the joint and provide some structural support for the joint cartilage and downregulate pro-inflammatory mediators. Dosing is usually 10 to 20 milligrams per joint, and high visc is usually what we're using. It's 22 mg per ml, off-label usage. And it also can be used often in combination therapy. It's been shown to have a synergistic effect with PRP, for example, but it might be limited by joint compartment space and how big your patient is in terms of how much you can inject. So pros are that it's relatively cheap and available, but the cons is that it's super short acting. And the efficacy is actually very questionable. In a lot of joint injection studies, it's now used as a positive placebo control. So it may even only last in the joint for just like several days. It's really quite short acting. So then going on to hydrogels, which is this exciting new area of injectates that we have to offer. And so starting with Arthramid, which is defined as 2.5% polyacrylamide gel. Its mechanism of action is that it integrates into the synovium and helps increase joint capsule flexibility. So completely different approach and different mechanism of action than all of the other injectates that we've been using to target before. And so the idea is that it helps reduce synovitis is the goal, and helps also improve the quality of the synovial fluid. And so what's nice is that actually, unlike a lot of the products that are out there in the canine world, that we have equine and human studies that are quite robust to support the use of this product. Arthramid under its human label, which is Arthrosamid, is available in Europe for intra-articular use. It's also used for cosmetic procedures in other parts of the body as Bulkamid. So we have a lot of safety data for that. And just recently, there has been a canine study that has been accepted by JAVMA, which is a large retrospective study showing generally positive results in like 83-ish% of the dogs, and minimal side effects. So good safety data. And I have to be fair and mention Spring as well, because I know what it's like to go to these veterinary expo centers and they have all these different products, and you will see this product out there. The actual constituents of spring are unclear. I think it's proprietary, but they say generally it's made from collagen and elastin, and it creates an osteocushion. And so the mechanism is to reinforce joint structures, replace missing or damaged cartilage, and provide a scaffolding to tissue defects. And so they have a single non-controlled canine trial that showed general positive effects in dogs, but it would be just nice to see more supporting evidence for this product. So that's what it looks like. And so in general, saying that, the pros of hydrogels are that we have a 1 year length of efficacy. The cons are that, of course, it'd be nice to always have more canine studies, but these things are building. And I would also add to the pros that generally these are quite affordable, not as cheap as using a steroid, but definitely much more affordable than purchasing a PRP system or going out and doing stem cell therapy. And then Sedation, speaking of expensive, is another new product out there. It is a tin 117 radioisotope. It works by deactivating macrophages and basically performing a chemical synovectomy to deactivate that damaged synovium. It has a 0.3 millimeter range of activity, so meaning that radioactivity is supposed to be contained within the joint. And they say that, and they're like, it's very safe, but you can't sleep with your dog for a month. So it's kind of like mixed messaging, but I guess they have to be extra safe. And the pros are that this is another product that has a 1 year length of efficacy based on the non-control studies that we have. Cons are that cost and general limited availability, given that not just anyone can just pop up shop and start using radioisotopes. And we actually don't have this product at UF because of all the red tape. I will also add to the con too, is that we do need more studies for this product too, for me to like really promote that additional expense. So going into some practical points, owner expectations, I think it's reasonable to tell your owners that they may be sore for the next 1 to 3 days, and that's to be expected. And so short-term pain medication can be provided in those cases. And the other thing to also say is that every patient is different. So we never know. I mean, even with carprofen, you never know who's going to react to which injectate. So, we can never say 100% efficacy for anything that we do. And then also injection of multiple substances is together is very common. So this is used a lot in equine practice and is becoming more and more common in canine practice as well. What we don't know is like if the benefits are additive or conflicting necessarily. We don't have enough information to tell us that. So complications, negative tap, that is something that can happen where you go in and you aspirate and you don't get that gratifying flash of synovial fluid afterwards. And so some workarounds are usually, try to push a small amount of like saline or something that doesn't really have very much resistance to it, to just see if maybe I'm in the joint. Usually if you will get too much, like a fair bit of resistance if you try to push something outside of the joint. Also using ultrasound guidance can enhance your visibility as well. And it's important to remember that sometimes in cases of severe OA, you're going to not have a lot of synovial fluid. Blood contamination is another complication. And like I said, usually just replacing your needle, swapping out when you get that contamination will prevent you from adding blood to the joint, which does not make it happy. And sepsis is extremely rare. So a study in 2023 showed 0.2% joint injection dogs had an issue with sepsis. So very, very, very minimal. Articular cartilage damage is possible for sure. And so making sure that, I think taking all the precautions you can to make sure you have your right landmarks, and redirecting your needle gently as possible and using ultrasound guided techniques could be a potential way to improve that. And we want to make sure we don't inject animals that look like this. So this is like an example of what these IMPA dogs look like when they're in stage. We're not going to inject IMPA joints or septic arthritis joints. I mean, actually, we do inject septic arthritis joints with in some cases we have this like slow release antibiotic gel, but that's a different story. Anything that you're concerned about neoplasia, or it's also a little controversial to inject steroids into a patient with a partial cruciate because you may further deteriorate that ligament. And then cocktails. So there are many different cocktails used. Like I said, we don't know the ideal combination, but there are many examples. PRP with triamcinolone, PRP with stem cells, PRP with HA, PRP with a hydrogel, and triamcinolone with a hydrogel. I think a lot of this is practitioner preference, but also depends on kind of what your goals are. Is your patient extremely painful where you need really fast relief? Then you're going to want to use something that has more of a quicker effect. PRP is a pretty quick effect and steroids have a pretty quick effect. So that's often why we're kind of pairing those things together. But I can say that we commonly use probably the triamcinolone. Well, we commonly use triamcinolone plus the PRP plus the hydrogel, or triamcinolone plus the hydrogel. And by hydrogel, I mean we are using Arthromed for the most part. And often you are limited by your total joint volume. So it might seem great to invite all your friends to the party, but canine joints are only so big. So I kind of made this little chart that kind of gives it like a little bit of an idea of, how you might decide between one injectate versus the other. Kind of gives you an idea of the information laid out there. So in conclusion, joint injections offer a targeted approach to OA management, and they are still an important part. It's important to remember that they are also just part of a multimodal protocol and that we can't skip all the other steps and just do joint injections, but they are a very powerful tool in your toolbox. And I know that there are many products available, which can be overwhelming, but things to take into account are patient, expense, and generally availability, and also level of evidence that we have out there. And we do have a building number of efficacy studies that are available in dogs. And the ideal product that's absolutely 100% perfect, we don't know what it is, but maybe someday we'll get there. And that's all I have for you.
Well, thank you, Dr. Repac, very much for that very informative talk. I think, it's amazing to see how far we've come from where we have oftentimes had NSAIDs and rest as our approach, and obviously diet and that kind of thing. Those are still very important, but I think having this targeted approach, and certainly with your expertise and what your colleagues bring to the forefront, and being able to combine all the different modalities, what we can and cannot do, and what we can really do to help our patients, I think is really, really key. Couple questions that have come up, and if anyone wants to put some additional questions in, then I will just certainly address those as well. So one of the questions that came up in particular is, any thoughts on Prostride autologous protein, which includes platelets and IRAP for joint injections in dogs?
Yeah, I mean, it's funny. It's because that was featured for some reason like in 3 questions on my board exam, but we like have so little evidence in dogs. We just, yeah, I mean, we have very little comparative studies between all of these different products, but we just there isn't enough information about it using in dogs to make it something that I would want to use in my practice.
All right. Um, One of the questions that often comes up in when I talk to veterinarians just across the country is, how to choose what to use and when. And one of the things I think you've done a really good job of explaining tonight is kind of what they are and that kind of thing. But, when you think about the joint itself and the anatomy of the joint and kind of where certain things work, and kind of, could you walk us through sort of your thoughts on how to use, if you are using a multimodal approach, sort of what do you think about and how would you start to kind of identify what parts of the joint you're trying to address and the disease? I've realized that, it's a loaded question, but I think it really does help to clarify some of the things when we look at the different modalities. And maybe you go back to that one slide that you had that had all of the different injectates and kind of walk us through that a little bit, if you don't mind.
Let's see.
That one.
This one here. Yeah. So, I think, I mean, there's I mean, of course I think about like the whole joint, but I think a lot of it is patient dependent, like that, like what's going on for that patient, what is their current pain level? Because if their pain level is very high, in some cases, triamcinolone might be just the fastest way to kind of shrink down that inflammation, like globally in the joint. Of course, it's a transient effect. But if I'm looking more in terms of overall enhancing the health of the joint, globally, and also maintaining their comfort more of long term, I tend to pick more of the like PRP and Arthro Fat combination, because I'm getting both of that more quicker onset of pain relief with that PRP offers by decreasing the inflammation inside the joint, as well as having Arthro Vet integrated to the synovium and bolster the synovium more long term. So it's kind of like a two-pronged approach. And we also have two-pronged in terms of short and long term as well, because it's actually been pretty nice in some cases that, I mean, so rarely do I see cases that like I see them right away and I get to intervene right away, and then they don't like fester for like months to years before coming to see me. But like a good example would be my parents' dog, who my parents moved across the country to be with their granddaughter, which is so sweet. And after being here for a few weeks, their dog comes up lame. And I'm like, why is your dog lame? Like, how does this happen? And so, of course, I did this like crazy workup on the dog, because I just had to make sure that he didn't have something horrible like cancer, and he had a CT, he got even an MRI, because I was worried he had like a peripheral nerve sheath tumor, but it ended up being that he had a little bit of shoulder OA and a little bit of supraspinatus and biceps tendinopathy. And so I was like, well, I'll just give him PRP and Arthromed into his joint, and like he did so wonderfully. Like I was able to, I mean, he was on NSAIDs and everything, and I was able to take him off all medication, and honestly, he's like never limped since. And I can't, I mean, that's in a very extraordinary case. But I think it really shows what you can do if you were to like intervene on lameness early. I get a diagnosis. I'm not saying you need to do an MRI on all your patients, but getting a diagnosis early, intervening early, you can have really extraordinary effects.
Excellent. So we had a couple more questions that have come in. One question in particular is, if you're giving PRP and Arthromed together, do you need to give the PRP every once a month for 3 months for that patient that's on Arthromed? So you come back and do the PRP consecutively, or just do it the one time?
So the answer is, nobody knows for sure. And I think it probably depends on the severity of your patient. But my reasoning for doing both at the beginning is, maybe if the patient is doing well in a month, and there's like they've become sound, they're doing just fine, then I'm not going to go back in that joint and just inject PRP for the heck of it. Like if they're doing fine, I'm going to leave it alone. But it's kind of a little bit of a new frontier, because we don't have like, by the book evidence that says that. And so we're kind of taking these on a case by case basis to see how they're doing at their 1 month recheck.
Excellent. Another question in conjunction with PRP and Arthromed is, do you inject them at the same time, or do you separate their injections by a couple of weeks?
Oh, that's a good question. We inject them at the same time, like and by at the same time, Arthromed comes in a very special syringe, so you don't put anything in that, but you would just attach your PRP syringe, inject your PRP, and then unscrew and then attach your Arthromed and follow up with that because it's quite sticky and it will clog up your needle for anything else that you do. So it's a good practical point to know.
Okay. So we have a couple more questions. This one is actually medical management. When medically managing a middle-aged dog with a supraspinatus tendinopathy, what is your starting protocol for this patient, and how do you recheck them, and how often do you repeat your injections?
So yeah, supraspinatus tendinopathy. So that's going to be, injecting probably more like PRP is usually the treatment of choice, and pairing that with shockwave. We'll often do the series of three, the magical number of three, which is just what people tend to use. I can't say that four is not better, but often they do quite well with a series of three. But that, of course, is important to use in conjunction with your rehab therapy, and they do have to be exercise restricted, so that they're not re-aggravating the injury. Tendons are very slow to heal.
Yes, indeed.
Yes, they take months and months.
Months and months, absolutely. Another couple of questions that we have is, how many joints can you inject at the same time?
Like how many joints? Well, I mean, there's no set number, but we often don't inject more than like two at a time, just because, I mean, it's, you know, it is a lot to kind of put the patient through if you're going to inject like all four legs at the same time. Also, if they're particularly lame on one side, it might be nice to just focus on that side and then observe if there's a change in their gait. Then you can see more clearly if you've targeted that one location. But I'm sure that there's a bit of practitioner preference there, but I would say typically no more than a couple of joints at a time.
Sure. Have a question in regards to, um, what is your post-injection protocol? Do you recommend strict rest for 4 weeks after Arthromin injection, as noted on the box, or rep indicated that it's okay to allow for some activity fairly soon after injection?
Oh, I didn't even realize that's written on the box.
I can kind of fill in for that, and that's a common question I actually get if you want me to step in and kind of
Yeah.
help with that. So in regards to that, what we recommend is 48 hours of strict rest and cage rest. And that's ideally because you've injected into the joint. You want to make sure that you're allowing that patient to recover in that time, and then gradually return that dog to exercise, or if they're in some type of rehabilitation program, they can slowly go back to that. And leash walking is what's recommended for the first 2 weeks, and then slowly from there, depending upon what stage of the OA that the dog is in, what's happening with that particular dog, just gradual return is what we recommend. And the dogs seem to do fairly well as far as that's concerned. If they're very excitable and that kind of thing, certainly if you need to use some medication to help kind of slow them down, take the edge off, that's certainly something that you can do and is recommended, because we just want to allow for that integration. It's really critical in that first 2 weeks when that integration is occurring into the synovial lining, just to help that joint. You don't want to have high impact things going on. Really want to reduce that amount of exercise and that kind of thing that they may be doing during that period of time. Another question that sometimes comes up is if the dog is in rehab and say they're undergoing shockwave or laser therapy or PIMP for something like that. What is our recommendation? Specifically with laser therapy and with PIMP, we recommend that you wait at least 2 weeks because we don't know how that's going to affect the integration with the synovium. And so we ask that you wait for 2 weeks. And that's just out of abundance of caution. The same thing in regards to shockwave. We recommend actually 30 days with shockwave over that joint. Now, if you want to go around the muscle and tendon, things like that, that's fine in those areas, in that general area, but you don't want to go directly over the joint that was injected. So that's really important to keep that in mind as well. And, as far as, rechecks and things like that, just like Dr. Repac was saying, we really encourage veterinarians to get those dogs back in 4 to 6 weeks post-injection so that you can reevaluate those dogs and see how they're doing, because I think that's one of the biggest things in doing these joint injections as a learning curve, especially if you're early on in your career of doing joint injections, is to see how these dogs change and being able to also do evaluations such as your CBPI and being able to utilize those validated studies to be able to help yourself and also your owner see the progress with these dogs. I think that's really a valuable tool that you can implement in your practice, as well as any type of video and that kind of thing. Do you have any recommendations that you all do, Jen, specifically for post-injection recommendations and kind of what your general rule of thumb are?
Yeah, I mean, I think usually we just say take it easy for the next like 2 to 3 days, like short leash walks only. But after that, we don't really put any specific restrictions because of the joint injections. I mean, the dog might be restricted because they have OA or cruciate rupture or something like that.
So that actually is a great segue into our next question, which is, when dealing with a cranial cruciate injury, that surgery isn't an option. Is there any benefit to using Arthromed, or does the structural instability make it ineffective?
That is a good point. I mean, you still have synovial disease. I mean, you have OA is going to be secondary to that cranial cruciate ligament rupture. It's not going to necessarily help stabilize the joint. I wouldn't expect that to happen. But it could definitely help with the pain associated with cruciate disease.
I would
And we've
also,
also used it in some patients, sorry, that have had TPLO in the past, maybe 6 weeks post or something like that, that we've done it too.
that was going to be my next question actually for you to follow through. Thank
Yeah.
you for that. So we have one question in particular. It says, my personal dog is 3 years old and has had bilateral hip dysplasia since it was 4 months old. I was told it was not surgical, so start Arthromed now? Or she doesn't show clinical signs of limping. I notice when she postures to defecate, her legs wobble a little.
Well, is she painful on hip extension? Because I think what's tricky is with bilateral disease, those can be very tricky to see an obvious lameness, especially if it's a disease that's more proximal limb, that's going to be more hidden. So, but I would just, I would see as the dog painful on hip range of motion. It is a consideration if you feel like when you actually examine her that she actually is quite sore, and there's also radiographic evidence of OA. The other question too is like, is she able to ascend stairs without bunny hopping? That's another test that I really like to use for hip comfort in dogs that are not super small. Like if they're super small, they're going to bunny hop no matter what. But if they're like normal size dog.
Yes. So another question that we have is there any evidence regarding Arthromed use long term? I'm wondering if we recommend this in an 8-year-old dog, are we then continuing annually?
Yeah, so you actually probably have a little more information because you have the insider scoop on the canine data.
We do. So in regards specifically to canine data, we don't have long-term data as far as that's concerned. It's something that we are certainly working to get and gain more and more of that information, but we do have it in our equine patients. And so we actually have data looking over 12-year data time period, and then also looking at a 10-year time period. And they've had repeat injections, and many of the volumes that they're using, believe it or not, even though they're horses, are actually very similar to what we have in dogs. And so really it goes back to looking at disease, and it's a very small amount of polyacrylamide. It's a 2.5% polyacrylamide, which is basically the tip of a pin amount, and the rest of that syringe is water. And so how it integrates what we've been able to determine is it integrates into areas that are more diseased and affected. And we know that this is a continuous cycle of disease. So we may, at the time of injection, you may be able to integrate into one area of the synovial lining that is worse. And then over time, we know that this is continuous. So it goes to a different area. And so if you have to re-inject, it may go into a different area and be able to integrate there. And so I think it's just a matter of understanding that cyclical aspect of this disease, that once it's started, it just never stops. And so being able to maintain the overall homeostasis and returning that joint back to homeostasis, the beauty of this product is you don't see the fibrosis that you see over time, and it allows for increased elasticity and tensile strength within the joint, and helps with that joint capsule, decreasing joint capsule stiffness overall, and really helping that synovial lining, which is where this disease originates, and helping to get the joint back to homeostasis and happy and healthy. And really, it just starts. A healthy synovium is what's the key to managing this disease overall.
And also they have some long-term data in the human side as well.
We do. And so that's the
Yes.
other aspect. We have quite a bit of data. We actually have a 5-year study that's just come out looking at it. And humans are very similar to dogs in regards to the age of the patients. These patients are averaged to be 70 years of age. And so a lot of our patients are end stage. And that's one of the reasons why we're really trying to get practitioners, really focusing on these dogs, because we know that there's evidence of radiographic changes that are occurring when these dogs are less than 4 years of age. If you remember the NC State study that was published, and really recognize that. And so I think it's really important to think about that because of the fact that, so many of these dogs are waiting until they're past, just like the diagram that Jen showed earlier, as far as we're already past the point of no return. And so if we could really do a better job in general and getting these patients early on and screening for them, in doing that routinely. And I realize a lot of them may not be in your hands to start with for some of you all initially, but certainly your colleagues that are general practitioners, I think this is such an area of opportunity to really start talking about. We spend so much time talking about dental disease and talking about parasites and heartworm disease and things like that. But joint disease is just as much, and mobility medicine is just as important, certainly in some of these breeds that are more predisposed to that. And having these conversations early on when these dogs are puppies, and helping to, do early screening and radiographs and things like that, just to get baseline, I think is really, really key. And we're seeing that how these dogs are managed more effectively, especially in some of these young working dogs, to be able to do that. So just to think about that. I see a question. How can I get the human arthrosamid injection done in my knees? You can actually go to Canada now. It's actually approved in Canada as we speak. And so if that's something you're interested in, we can certainly get you some information as far as that. And Rachel can help with that as well to provide you that information. But that is definitely something, it's a game changer, that's for sure.
Well, thank you both so much, Dr. Green and Dr. Repac, for your very thorough discussion tonight. It was very informative. And so if you guys have any follow-up questions that we didn't have time for today, tomorrow by end of day, you will get your CE certificates, and we'll also include a recording to this presentation. So if there's anything that you want to go back to and rewatch, you're welcome to, as well as we'll include the link to the joint injection videos that she showed if you want to reference those. I also put them in the chat tonight, so if you want to look at them easily while it's fresh, top of mind, you can do that as well. And if you have any follow-up questions, of course, please reach out to us, but we sincerely appreciate you guys taking time out of your busy schedules to attend tonight, and we are super appreciative. So With that, everybody have a wonderful rest of your evening and have a great weekend.
Thanks, guys.